thank you so much, Libby, and hello to everyone, both here live and also everyone online. It's great to have you with us today. Just a disclosure that I don't have relationships with commercial interests, and I've been a member of a leadership team for a project called the Fountain of Health, which I'll talk about a bit later on. And we received funding from the Center for Aging and Brain Health Innovation for this particular project recently. And I've also been project lead on a project to create substance use disorder guidelines for clinicians related to older adults. So I'm going to talk about what is mental health, about aging and mental health, about arthritis, pain and mental health, and some ideas about coping with pain. And we'll talk about prevention and health promotion. So by the end of this session, I hope you'll be able to understand how having arthritis and aging can impact your mental health and vice versa, identify strategies to promote emotional and mental well-being while coping with or supporting someone living with chronic pain, and identify sources of further information and support. So what do you think about this image? This is actually from Health Canada a number of years ago. Do you think this represents healthy aging? How many? Hands up if you think it does. Online as well. A number. Does anyone think it doesn't represent healthy aging? See, the thing is, well, they're passionate and they're socializing, which is good. They're developing new experiences, but they're not exercising really, maybe a little bit. And they're polluting the environment, and they might be setting themselves up for injury. So, you know, it's a bit of this and a bit of that. But I love the image myself anyway. So, now, arthritis is a complex disease with over 100 different types. Some of those are inflammatory arthritides, and some of them some are listed here. But the most common form is osteoarthritis, which affects so many older adults. Many individuals with arthritis also have other chronic illnesses like heart disease or diabetes. People with arthritis are more likely to experience anxiety, mood disorders, and poor mental health and difficulty sleeping compared to those without arthritis. And while arthritis affects people of all ages, the likelihood increases with age, so that nearly 1 of 2 seniors over 65 have some form of arthritis. So what is mental health? Well, it could simply be an absence of mental illness. That's a simple definition. But it also reflects the ability or capacity of an individual to deal with the issues of life in an effective, if not pleasurable or satisfying manner. Riff describes 6 psychological characteristics of mental health that include self-acceptance, positive relations, autonomy, environmental mastery, having a purpose in life, which I think is critical at any age, and personal growth. Well, we all want to be happy. The question is whether happiness is even normal given the strain and stresses of life. The pattern, this is interesting. If you look at, on average, if you look at happiness through life, different ages, you'll see the ages there, different decades at the bottom. It looks like the bottom is actually in the 40s, and then happiness seems to increase in later life. How many of you are surprised by that? Not that many of this group. Interesting. I'm always struck by this statistic, actually. It's very interesting. Why are the 40s so difficult? There was a fascinating study done in San Diego on successful aging. So they looked actually at individuals between the ages of 21 and 100, doing phone interviews, mail-in surveys, and so on. It was a complex study. But if you look at this finding, so physical health declines through life. That's no surprise. Aging is difficult. But sense of well-being seems to increase all the way through life. Now, isn't that remarkable and maybe a little hard to explain? But that's what the data showed. So why are older people happier on average? We're just talking about on average here. So some researchers suggest that they may expect life to be harder and learn to live with it, or they're more realistic about their goals, only setting ones that they know they can achieve. A researcher by the name of Carstensen thinks that with time running out, older people have learned to regulate their own emotions, focusing on things that make them happy and letting go of the things that don't. There are descriptions, of course, about how to be more optimistic, how to develop a positive attitude. And some of these simple ideas actually can be helpful. So, actually looking at the bright side of life, or, when you smile, the whole world smiles with you. Having faith in yourself and the power of the universe, which, raises the whole issue of spirituality and the benefits of that potentially. Associating with positive people, that does seem like a good idea. It doesn't mean getting rid of all your friends who might be going through a hard time, of course, but read inspiring stories, repeat affirmations that inspire and motivate, visualizing the things that you want to happen, and learning to master your thoughts. Meditation. So Sasson describes all of these as steps you can actually take to have a more positive attitude. There was an interesting study a number of years ago out of Yale that divided middle-aged people up into two groups. So one group had a more negative view of aging, and the other group had a more positive view of aging. And they studied these people for several decades, and the remarkable finding was that the group that had a more positive view of aging lived, on average, for more than 7 years longer than the group that had a more negative view. Now, you could sort of argue about what was the cause and effect there, but it was a fascinating study. So when it comes to mental illness among older adults, in general, older adults have the same kinds of issues as younger people. So mood disorders, particularly depression. In fact, sadly, there are actually high rates of suicide, especially among older men. There are anxiety disorders, psychotic illnesses, and then, of course, as we age, we're more likely to develop cognitive memory problems, which include dementia, and Alzheimer's disease being one form of dementia. There are many stressors associated with aging: physical illness, including arthritis, sensory deprivation, retirement, bereavement, social isolation, the loss of roles and status in society, and financial issues. These are just some of them. So again, you would think with all these challenges that maybe older people would be more depressed. So as this road sign says, that some people may be depressed for a good reason, and for many good reasons perhaps, and others might be depressed without any clear stressors or problems in their life, and we think of those people as potentially having more of a chemical depression perhaps, and with a strong family history of depression. But most people who get depressed, there are reasons why. So this is taking you into the mind of a psychiatrist right here, okay? So psychiatrists think of the biopsychosocial model, which sounds kind of fancy, but what it really means is that there are many factors that come together when we have a particular emotional or mental problem. And the biological refers to more physical or chemical things going on in the brain, or medical illnesses, drugs, medications that can actually cause depression. The psychological factors are related to stressors in a person's life, to changes, perhaps to personality issues, and then the social and environmental issues could include all sorts of challenges related to one's social life, including social isolation, which is a big problem for older people. So when we think about an individual, let's say, who's depressed, we try to think about all of these things when we're thinking about strategies that might help. So how do we treat someone who's got a serious depression? The first thing that you might think of are antidepressant medications, and we have a whole range of different antidepressants that certainly help some people. And if you compare the effects of an antidepressant to a placebo, in most studies the antidepressants are better than an inactive placebo. Although, surprisingly enough, placebo is quite a good drug as well. The inactive substance that a person gets in a pill that has really nothing in it actually works quite remarkably well. And we always wonder about why. Does that make any sense? We think it's because people, when they're enrolled in a study, actually get really looked after. They're seen regularly, they're evaluated, they have a lovely research nurse who speaks to them and gives them a cup of tea. That's a social event. So a placebo is not just a placebo. Then we come to psychotherapies or talk therapies, which surprisingly, it might surprise you, but psychotherapies are remarkably effective in helping people with depression. The one that's talked about a lot is CBT, or cognitive behavior therapy. We'll talk a bit about that later. There are also other interventions, various forms of electrical stimulation, neurostimulation. Transcranial magnetic stimulation is a new one on the block that seems very interesting and is a very benign kind of treatment. Exercise. Believe it or not, exercise alone can be a very effective intervention for major depression. Light therapy for people who get more depressed in the winter. So let's talk a bit about pain. So there are different ways of understanding pain, different models. The biomedical model is that simply pain is the result of an underlying disease. So you have an arthritic joint, it hurts, that's it. That's a simple model. The gate control theory is that pain is actually influenced by higher brain centers responsible for cognitions and emotions. So I have a quote here from Dr. Turk from the University of Washington, who says that the rain of pain falls mainly in the brain, which means if we didn't have a brain, we wouldn't actually feel much pain. And that's why what I'm going to say next is that emotions, depression, stress can all affect our perception of pain. And the cognitive behavioral model includes these various factors in contemplating why we have pain. Now, this comes from the Arthritis Society website. This is the most important slide I'm talking about today. So it basically says that, yes, you have disease, it creates pain, but there are all sorts of factors then that contribute to that, as I was just saying. So that could start with your muscles becoming tense, which could happen when you're stressed or anxious. That if you're fearful or angry or upset or frustrated or relationships aren't working, this can affect your mood. You can become depressed. Depression leads to fatigue and low energy and reduced activity and isolation. And all of these things interact to heighten the pain. A fair amount has been written about the psychological approaches to understanding and treating arthritis pain. In this particular paper, the discussion focuses on actually training in pain coping strategies. And there are a whole variety of these that really revolve around actually a cognitive behavioral approach. And some of these are really basic, like learning relaxation techniques. Mindfulness has become very popular. Positive visual imagery, pacing one's activity, taking a problem-solving approach where you actually define what is the problem you're struggling with and try to come up with solutions. And cognitive restructuring, which sounds really fancy, but what that really means is trying to think more deliberately and positively, because if you're depressed and in pain, there's a natural tendency to think negatively. We think negatively about ourselves, about the people around us, about the future, about the world. So the cognitive behavioral approach actually challenges us and says, okay, let's write down what we're thinking and how it makes us feel. A lot of homework involved. You got to keep writing it down. But the goal is to either work with a therapist or on your own to actually challenge those thoughts and realize that perhaps you're thinking too negatively. And a lot of studies suggest that those kind of changes really can make a difference. In this particular paper, they recommend rehearsing these various interventions, potentially with a therapist, so that they can be applied when a person is in pain. They also stress emotional disclosure. So if you bottle up your feelings and emotions, and I'm not looking at the men in the audience, but men are really bad often at really talking about their feelings. But if you don't share your feelings, this can also intensify pain. And then including your partner, your family, where it might be appropriate, sharing with them what you're feeling and what's going on and how to learn coping together. Just very briefly, I wanted to mention that, as a society, we tend to turn to drugs, to medications, there's got to be a magic solution, right? So, I've been talking about therapies, about a whole variety of psychological interventions, but we tend to focus much more on having a magic pill. And sometimes there is a magic pill. Sometimes a medication can make a huge degree of difference. But there's been a fair amount of focus lately on older adults and substance use disorders. And as I mentioned at the beginning, I've been working with the Canadian Coalition for Seniors Mental Health on a 2-year project to create national guidelines on substance use disorders. They've just been released. And just in a nutshell, you might be interested to know that we've come up with new low-risk drinking guidelines for older adults, which are about 50% of the number for younger adults. And so what we're suggesting is that for men, 7 drinks a week, standard drinks a week, no more than 1 or 2 in a day, and for women a little less, 5. It's because of different metabolism that the number is a bit lower for women. So that doesn't mean everyone can even drink that amount. We would suggest that some people with chronic illness, perhaps who have cognitive problems, maybe should drink less or maybe not at all. In our guidelines on a group of drugs called benzodiazepines, which are treatments like lorazepam and diazepam that are used a lot for sleep and anxiety, we actually suggest that these drugs should be really only used minimally, and if at all, for very short periods of time. Opioids, a big issue for chronic non-cancer pain, should be avoided in most circumstances. There are many risks, and the risks often outweigh the benefits. Every person is different, though, and we don't generalize completely. These are general rules. And we also suggest a cautious approach to the use of cannabis in older adults and the need for more high-quality research, and you'll be hearing more about that in the next talk. So an ounce of prevention is worth a pound of cure, as Ben Franklin said. So we're all concerned as we age about our memory, about the possibility that we could have cognitive decline or even develop dementia. And a paper in The Lancet, that's the British journal, 2 years ago, suggested that there are modifiable risk factors for dementia, so things we can do to reduce our risk. They even went as far as to say that if all of these things listed on the screen there were actually carried out, we could potentially delay or prevent 1/3 of all dementia cases, which would be a dramatic change in our society and the healthcare costs. So the 9 modifiable risk factors are education, hearing loss, obesity, hypertension, smoking, physical inactivity, diabetes, depression, and social isolation. So in other words, if we were to intervene in all of these things, and if people could actually change some of their behaviors, such as getting a hearing aid if you really need one, giving up smoking, looking after your blood pressure carefully, these things could have a huge impact actually on reducing the risk for dementia across society. There are many lifestyle approaches that can improve brain and mental health. And, I don't really think of mental health and brain health as being different. It's all integrated. So all of the things listed here are both good for your mood, but also good for your memory and cognition. So the things listed here include, again, physical activity, social activity, engaging your brain, and a healthy diet and weight. And I know with arthritis, one of the critical challenges is, how do I exercise or be more active when that makes my pain worse? And so that is one of the greatest challenges with arthritis, I believe. And it needs very careful management and encouragement, I think. And obviously, being as active as we can, given the limitations, is the goal. And yes, maybe it does make sense to push oneself. What we're looking for sometimes is just small changes that can actually make a big difference in the long run. So yes, physical activity is the best promoter of brain neuroplasticity across the lifespan. And neuroplasticity refers to the fact that our brain, even as we age, can actually still grow and develop. We can develop new pathways in the brain by challenging it and by becoming as active as possible in terms of our keeping the brain active and exercise. So it is said that 150 minutes a week of moderate exercise is the ideal. That might be okay for a younger person. Some older people are fine doing that. Other people, perhaps with serious arthritis, might find that impossible. So, but all forms of activity help. Simply not sitting is helpful. Light physical activity, 15 minutes, is a comparable benefit to giving up smoking. In other words, if you engage in 15 minutes of light physical activity a day, that can make a big difference. And there's been studies showing that for every daily flight of stairs climbed, you actually increase your brain gray matter to the equivalency of about half a year younger than otherwise. So lots of good evidence. So there are reasons to make a change. So exercising never gets old. You reduce your risk of dementia, you lower your risk of chronic illness and disability, you improve your mood, better sleep quality, maintaining function and independence, decrease risk of falls, and increase longevity. Social activity, also very important, and the health risks associated with loneliness are of a similar risk magnitude to smoking and obesity. Isolation is an independent risk factor for developing dementia. Secure relationships, the single most predictive variable in well-being in later life. Challenging one's brain. So yes, doing all sorts of things that can keep the brain active. So there's no question that, the more education you have through life, the lower your risk of dementia. Complex, novel activities help the most. Changing routines can help. Playing games, bridge, reading, watching television, and we're in the Zoomer studios here. Some television shows are wonderful and keep your brain active, but we have to be careful not to become couch potatoes. So what about diet? Now, we know diet is important, and it doesn't take a genius to realize which of these two groups of foods are better for you and increased benefits with a Mediterranean diet are clear-cut and seem to help us, certainly in terms of our brain function and mood. Mind you, there are tomatoes in the bottom breakfast there. That brings me to the Fountain of Health initiative, which actually started out in Nova Scotia. Dr. Kerry Lee Cassidy, who's a geriatric psychiatrist there, and her colleagues developed this lovely program. If you go to the website, fountainofhealth.ca, you'll get a huge amount of information on how to make changes, positive changes in your lifestyle that can help you be healthier. The Fountain of Health actually focuses on these 5 areas, so social activity, positive thinking, physical activity, mental health, and lifelong learning. It's very hard to change one's behavior for all of us. And there are many excuses. The common excuses are, I am too busy, stressed, old, sick to do anything or to change anything, or this isn't really relevant for me or my medical situation, or it's too late for this to make a difference for me. Or if I try this and it doesn't work out, I'll fail or let people down, or this goal is too small to matter. And these are all myths. So the Fountain of Health actually creates behavior-changing tools, very simple ones. They're available to clinicians, to health professionals, to use with their patients, their clients, to help their patients make simple changes. Because, we can educate, we can provide information to people, but what is it that will make a difference to help people actually make changes? And so we find that these tools can make a big difference. And as clinicians, we have to change our behavior because most of us actually didn't grow up learning about health promotion and how to help our patients make these kinds of changes. So the behavioral change is inherent for clinicians as well as for our patients. So the Fountain of Health has a wellness app, which you can find about on the website as well. 3 simple steps. So first set a baseline, then set a SMART goal, and then track your progress, and then repeat. And So what is a SMART goal? A SMART goal is something that is specific, measurable, action-oriented, realistic, and time-limited. So here are some examples. So physical activity, walk to the mailbox 3 times a day for 1 week, or get up during the ads, during the 6 o'clock news, 4 times a week. Social activity, call a friend or family member once a week. Set up a coffee date once in the next 4 weeks. Under brain challenge, read the paper 3 mornings a week or listen to a radio program twice a week. And there are other things we can do for our mental health, like attend a yoga class once a week for 4 weeks, write a gratitude journal, or meditation, even for short periods of time. And of course, it takes, you have to learn how to meditate. You can't just do it. And then tracking one's progress. There are different ways of doing it, either using online materials or simply writing it down. But what we find is that if people set a goal and actually write it down and then track it, and you can either do that on your own or maybe with your physician or another health professional, we've studied this, and it's so many people report that, yes, they're at least partially meeting their goal, which is really exciting. So finally, I wanted to mention that the Arthritis Society has an amazing website. And I hadn't seen it before I was invited to give this talk, and I thank the Arthritis Society for this opportunity. But there is some really fantastic advice. It's really well written. It's simple to follow, and it's really sensible. And you can find lots of material there. There's a whole section on mental health and well-being that I would strongly advise you to look at. So in conclusion, arthritis is very prevalent among older adults, causing considerable pain, loss of function, and reduced quality of life. And people with arthritis are more likely to experience anxiety and mood disorders, poor mental health, and difficulty sleeping compared to those without arthritis. Experience of pain is influenced by higher brain centers. Emotions, thoughts, and social interactions can influence pain. And the treatment of pain can be optimized with an approach that includes the learning of coping strategies. Older adults can benefit from treatment for depression, anxiety, and other mental disorders with either psychosocial interventions like psychotherapies or medications, particularly when the depression, for example, is more severe. So with a more severe depression, a combination of talk therapy and medications is usually optimal. At the same time, older adults should be cautious about the use of medications and should engage in open discussions with their physicians and other health professionals about the risks versus benefits. And older adults are susceptible to substance misuse and substance use disorders. The Fountain of Health tools can help us to set goals and make positive lifestyle changes. And I'm happy to stop there and take some questions, comments. Thank you.
Thank you very much. Everyone have a seat with me. That was a great presentation. Thank you very much.
Thank you.
As we mentioned, we've been getting some questions in online, so we'll start with those. I have to get my glasses on to read them. So first question, what are the ways to stay positive when you're dealing with chronic pain?
Yeah, so I think that there are a whole variety of things, as I've mentioned throughout the talk, that can help a person be more positive. And for each person, those kind of things are different. But I would say, first of all, it helps if you have other people in your life that can assist and can help you to be positive. And as Sasson said, it's good to associate with positive people, and hopefully either a friend or a family member, someone who can be a bit of a cheerleader. That can be really important. I think realizing and reflecting on one's own thoughts. So realizing that you might be depressed, and that's not unusual, and it's really understandable when you're dealing with chronic pain. So many of the strategies I talked about throughout the talk, I think, can be employed. But I think actually writing down one's thoughts and then one's feelings and trying to see if there's a link between the two. There's a very good book called Mind Over Mood by Greenberger that's designed for individuals to help them look at their thoughts and feelings and how they interact. And that approach, and there are other best-selling books as well that can be really helpful in looking at the connection between emotions and thoughts.
Okay, next question is how to cope with grieving the loss of things I could do before arthritis?
Yeah, so as it says on the Arthritis Society website, when we think of grief or bereavement, we think about the loss of a loved one, but there's also a grieving process that takes place as we see a decline in our physical health, as we're dealing with chronic illness. And it's important to realize that and reflect on that. And there are all sorts of very normal emotions that one goes through when one is dealing with grief. And so again, reflecting on those emotions, not so much as being very, very negative or unusual, but actually it's a normal process as we adjust to our new selves, as we, all of us, as we age, have to cope with a lot of these changes.
Can antidepressants help with osteoarthritis pain?
Yes, so antidepressants, of course, are good for mood, and they're also good for anxiety, actually. So if you have a lot of very serious anxiety, antidepressants are actually the medications of choice if you need medications. But there's some evidence that certain antidepressants seem to actually be helpful for pain as well. There's one called duloxetine or Cymbalta that where there's some pretty good evidence that it can help both depression and pain. So physicians will often prescribe that kind of antidepressant. It's called a dual-acting antidepressant. It works on two different brain chemicals.
How can I motivate myself to stay active when I'm in a lot of pain?
Yeah, so as I talked about earlier, this is the $64,000 question in a way. It's so hard to keep moving if it's going to increase pain. And so I think the goal is to realize that in the long run, by keeping more active, by being more physically and socially active, you actually can feel better. But there's a sort of long-term gain in a sense, but it is definitely a struggle. And so I think that calls into play the fact that there are treatments for pain, again, both non-pharmacological and pharmacological. So finding the right mix that can both limit the degree of pain that a person has to the point that, yes, you can continue to be active. Finding that right balance is really critical, I think.
If I can throw in something from my own experience, I have quite a lot of arthritis in one of my knees, and the only thing that works for it is exercise.
Yeah, so exercise can help, right? Yeah, the right mix of rest and exercise. And yeah.
Okay. How do you break the barrier when someone has anxiety and is afraid to go out?
That's a really excellent question. And there's no question that, first of all, individuals with pain and individuals who maybe are struggling with other issues, such as balance problems, or someone who's had a fall, perhaps a serious fall, it's very easy to become afraid and so fearful that you just want to stay home where it's safe. Again, I think this is where you might want to work with a health professional, with a therapist, to try and overcome that anxiety if it's really severe. The other thing I think is to employ some of the simple techniques that I mentioned earlier, like relaxation approaches, where deep breathing and positive visualization can actually help to reduce anxiety. And again, doing things in very small steps, literally. Having small successes can lead to greater successes.
What can someone in their 30s do when they're already having memory problems?
Well, that's unusual that somebody in their 30s would have memory problems, although, you know, our brain probably peaks at around age 20, and, you know, some people say it's downhill after that. But in truth, most people in their 30s who are starting to experience memory problems might be under a lot of stress. They might have a lot of anxiety or even depression. It would be unusual for it to be more of a neurological problem at that age. That would be not impossible, but rare. So I think the important thing would be to look at some of the common things, like high levels of anxiety and stress, which, you know, are very common at all ages.
Okay, let's open it up to the studio audience. Does anybody have a question?
Just 1 sec. Hold on. Hold on.
Yeah, why don't you tell us your name first, please?
Yes, my first name is Marion, and I'm wondering why you hadn't mentioned surgery. I had excruciating osteoarthritis about 14 years ago. Medication didn't cut it. And so I was recommended to have surgery, and I postponed it for 3 years, and I could not walk a block by that time. So if I hadn't had the bilateral hip replacements, I would probably be in a psych unit now in a wheelchair. So I just wondered why you hadn't mentioned surgery as an alternative.
Yeah, there's no question that there's a very interesting pyramid design produced by Health Quality Ontario, and the bottom of the pyramid are the largest group of people, and then at the top of the pyramid are smaller numbers of people. And when it comes to arthritis, there's a huge number of people at the bottom who have milder forms of arthritis, who can manage, you know, with a little medication, with exercise, with physiotherapy, and so on. Then as you climb the pyramid, there are smaller numbers of people with more severe arthritis. And on the top group, and they actually said it was 4% of all people with arthritis who really need surgery and can truly benefit from surgery. So it's the people who have, you know, obviously if there's no cartilage left in your knee, you can't walk very well without excruciating pain, and a knee replacement can be a miracle. Obviously, you have to have the courage to go forward and do that, but you're absolutely right. You know, with severe arthritis, surgery can be miraculous. Thanks for that question.
Any other questions? Yes.
Go ahead.
I'd just like to know what the current data is on the biologic group of treatments, the injectables, if the data is down, and if, in terms of effectiveness and where they're developing.
So these are biological treatments that are used primarily for the inflammatory arthritis and autoimmune diseases, and there's a whole range of those relatively new medications that, again, can be very helpful. It's a bit beyond my area of expertise to be able to give you an update on those, but I know that they're part of the armamentarium for some forms of arthritis.
The only reason I'm asking is because I'm on biologic, and the initial, I'm on a different one now, but they were very, very effective initially when I was really quite suffering.
Yeah. And could I ask what type of arthritis
Well,
you've been?
I was on something called Enbrel at one time.
Ah, yeah.
And it kind of ran its course, and now I'm on a different one. I don't
Yeah.
want to speak about the you know, the particular brands.
Sure.
And I'm just starting the second series now, and it seems to help quite a bit.
Fantastic. That's really wonderful. And look, there's science is advancing. We're learning more and more about the underlying causes of the various forms of arthritis and other chronic illnesses, and biological treatments can make a big difference for many people.
Mm-hmm. Thank you.
There was one over here. Daria? This lady here? We're out of time. Here? We're out of time. We're out of time? Okay. Sorry about that. By the way, if you had online questions that we couldn't answer, you can send it to Arthritis Talks at arthritis.ca. And Dr. Conn, thank you so much.
Thank you, Libby. Very nice to meet you.